I want to thank Dr. Chow and thank Paige and Alice for all the great organization here, and great to see this wonderful building. And thank you, AIM, also for helping us to organize this meeting. So my topic is acral and mucosal melanoma, and that's a little bit different than the types of melanomas that we've been talking about just a few minutes ago. And so as Dr. Ye pointed out, so the acral melanoma is the kind of melanoma that you get on your fingernails, on your palms and soles, and you could see how some of these look like. You could see that it could be like a streak on your nail, or it could be kind of like a brownish, blackish spot, and sometimes you could see like right over here, like a lesion on the side of your foot, or on the sole part of your foot. So that's the type of melanoma that arises from non-hair bearing skin. And then mucosal melanoma is a type of melanoma that happens in your mucosa, like it could be in your sinuses, or it could be in your lip. And you can see all of these different locations. It could be in your tongue. Sometimes can happen, in women in the vulva or vagina. It could also happen in the rectum, and these have a different biology as compared to your skin melanomas. And as Dr. Ye was talking about, most cancer, we think, goes through a bunch of stages before you actually get to the cancer. And you start off from a pre-cancer lesion to, it has to go through all of these different steps, right? And it's either ultraviolet exposure that's responsible for cutaneous melanomas that causes all these different steps, like the nevus, and then dysplastic nevus to the point where you have a melanoma. But right over here, you have melanomas that don't have a lot of sun exposure, just obviously based on their sites. And so I think we're still filling in the pieces with how these mucosal and acral melanomas actually come to be, what steps they go through. And if you look under the hood, today's thinking is that almost all cancers have to have a mutation to become a cancer. And so if you look at acral and mucosal melanomas, they're different. And this was a study from Australia. And so you could see that in skin melanomas, the average number of mutations is 79 for a standard garden variety skin, 36.3 for standard skin melanoma. Now, if you look at the eye melanomas or uveal melanomas, it's almost a very low number of mutations. But if you look at mucosal and acral melanomas, you could say that there's 10 to 20 times less mutations. But what you do see a lot in these two types of melanomas is rearrangements. And so rearrangements are kind of genetic abnormality, but not a mutation. It's exactly, but the chromosomes are scrambled, and that's what we think is going on with these acral and mucosal melanomas. And so, apologize for this busy slide, but basically, if you look at the standard skin melanoma, so if you look at your skin melanoma, you could see that that's what's happening here, and all of these lines are one single tumor. And so you could see that in the skin melanoma, cutaneous melanoma, you see a lot of these lines are in this one pathway called the MAP kinase pathway. And think of it as like a pathway that the cell uses to sense the environment. And a lot of the mutations are right there. Now, if you look at the other different types of melanomas, if you look at, like, for example, here, you still see a lot of mutations and abnormalities in the MAP kinase pathway. But you do see a very different pattern from the normal skin melanoma. And if you look at mucosal melanoma right here, you can see again, similar pattern of abnormalities, lots of mutations in the MAP kinase pathway, but not as many point mutations, but a lot more of these deeper chromosomal abnormalities and rearrangements. And then if you look at your eye melanoma or uveal melanoma, you could see that almost no mutations in the MAP kinase pathway, but different different pattern of mutation. So basically just seeing that under the hood, these tumors are pretty different. The skin melanoma, your garden variety skin melanoma looks very different once you look at the pattern of abnormalities. And again, this is just another way of visualizing that. That's the top panel is cutaneous. The middle one is acral. The third one is mucosal. And the fourth one is uveal. And so what you're seeing is that a lot of these, like this big line here, these are basically abnormalities in the chromosomes. And you could see that in the skin melanoma, you're seeing this type of pattern. But with acral melanoma, you're seeing a lot more of these different types of DNA abnormalities under the skin. And then similarly, if you look at the uveal melanoma, you're seeing like in this chromosome 8, you're seeing all of these changes there that are pretty distinctive for this type of cancer. So what does that mean in practical terms? The one kind of mutation that's abnormal and that's being targeted, and Dr. Ye's worked on that a lot, is on KIT mutations. And so if you look at mucosal melanomas arising in the vaginal area, about 25% of them will have KIT mutations. And the acral melanoma, the one that you get on your fingertips and stuff like that, that's about 15%. And the mucosal melanoma arising in your sinus is about 5%. And you don't see a lot of the BRAF mutation that Dr. Chow was talking about. About 40% or 40 to 50% of skin melanomas have this BRAF mutation, but it's only about 10% in these acral and mucosal melanomas, and about 10 to 15% will have NRAS mutations. So different pattern of mutations. And if you, again, looking under the hood to see if you biopsy patients, and if you look to see, okay, if you biopsy a patient who's had a response to treatment versus a patient who has not had a response to treatment, what are you going to see? We did this study at UCSF a few years ago with my colleague Mike Rosenblum in the skin program. And basically what you can see is that if you look at responders, they have a lot of T cells in them. And they have a certain type of T cell that have checkpoint expression, and we call them exhausted T cells just because that's an easy way of referring to them, even though they're not really exhausted in the sense that they haven't run out of gas exactly, but it's more that they have some checkpoint, they have some extra brakes on them that cancer can utilize to turn them off. And that's how our checkpoint treatments work. And if you look at what happens in, like, say, pneumonia or flu infection or something like that, when a T cell gets stimulated, or let's say you have a vaccine, or let's say you got the flu, the T cells get activated. And then the activated T cell, once the infection clears, becomes a memory T cell. And that memory T cell can be there for the rest of your life. And that's why once you have immunotherapy, you can have a lifelong resistance to the melanoma coming back, right? But what happens in cancer typically is that these T cells get exhausted and start expressing checkpoint molecules in them. And PD-1, that's how Keytruda or that's how Opdivo works by blocking PD-1. That's one molecule, or CTLA-4, which is how the Yervoy drug works. That's a CTLA-4 inhibitor that works on that molecule. So what is currently thought is that as long as the cancer is present, you don't form these long-lived memory cells. And that's part of the problem in cancer treatment is to try to induce these cells. So if you look at different subtypes of melanoma and see how much PD-L1 expression they have, and that's a marker for the presence of these exhausted T cells, you can see that different melanomas have different numbers. So like your normal skin melanoma, about 60% of those will have PD-L1 expression. And if you look at acral and mucosal melanoma, it's about 30 to 40% of them will have PD-L1 expression. And that's how it looks like under the microscope. It just shows at the border zone between the tumor and between the rest of your body, you have this zone where you can see this type of PD-L1 expression like you see like right here in this middle panel. And if you look at patients with acral melanoma, and this was a study that was done a few years ago now, basically, if you look at skin melanoma, if you look at somebody who's had total response to immunotherapy versus no response to immunotherapy, you could see that like a person who has had a good response to immunotherapy has a lot more T cells in their tumor versus somebody who's where the tumor is spread across the body. And you see the same thing with acral melanoma too. You see the same difference that a immune responsive tumor has a lot more T cells in it. And if you look to see how people respond, it's generally what you'd expect, that if you look at your standard skin melanoma, you can see that in a skin melanoma, this line here shows that about 40 to 50% of people will have some kind of benefit and will remain disease-free. If you look at the acral melanoma, that's the melanoma on your nails, you can see that in many ways it's similar, maybe not as good as skin melanoma. But if you look at the mucosal melanoma, you could see that with this, with Opdivo alone or nivolumab alone, you can see that patients generally don't do as well as they do with skin melanoma. And so one study I found was this Dutch melanoma study in Europe. There's a lot of countries have countrywide registries, so you can actually look up and see how people are doing. So in this Dutch registry, basically, if you look at just response to single agent immunotherapy, you could see that in skin melanoma, about 54% of patients had a response, while in acral melanoma, 34% of patients had a response. And if you look to see if they use combination therapy, the Yervoy and Opdivo treatment that Dr. Vaidya was talking about, which is becoming the standard of care now for neoadjuvant therapy, you could see that for skin melanoma, there was a 53% response versus 33% response for acral melanoma. Now, when you look at those numbers, you might be like, well, that doesn't look like it's a lot different, right? They look pretty similar whether you use single agent or not. And I think that's one of the issues with these registry studies, that we don't really know what types of patients were treated. And so we're just getting data for patients who walk in. It could be that people in this group here were maybe more advanced. And that's why, and that's why the doctors decide to give them these particular treatments, right? So I think to summarize the data from this study, the question they asked was, what was the benefit of using combination therapy over single agent therapy alone? And so here are the numbers. They had 184 patients who got PD-1 alone, and then 69 got IPI plus PD-1, and then 82 got IPI alone. And basically, here's the response data. And so you could see that from about a quarter of patients had a response to PD-1 single agent therapy, and the combination gave you about a 43% response rate. So you got some benefit from this combination therapy, and the study was presented at our ESMO meeting. And so it just shows the difference. And these differences were statistically significant. So you got about twofold more response from the combination treatment. And then if you compare them all together, here's the comparison between the combination IPI plus PD-1 treatment versus PD-1 alone. So if you look at skin melanoma, just your standard skin melanoma, seems like you do have some survival benefit, but it's a small survival benefit between the combination treatment and between PD-1 by itself. But then look here, if you look at that second row here, that's mucosal melanoma, you could see that there's a huge difference, right? So you could that kind of suggests that for somebody with mucosal melanoma, maybe they're getting more benefit from the combination versus from the single agent treatment. And then for patients where you didn't know what the primary site was, there's a certain percentage of patients, maybe 5 to 10% of patients with melanoma, where we don't, we just find it in the lungs or we find it in the liver or find it somewhere else. Patient does not have a history of melanoma or doesn't, hasn't previously been picked up with melanoma. And so in that case, you can see that there is some benefit from giving them combination treatment versus the more intense type of immunotherapy versus the simpler type of immunotherapy. And then for acral melanoma, again, in this study, seemed like there wasn't a huge benefit in giving them combination therapy versus single agent therapy. Now, I think this is up for discussion, as to these studies are retrospective and they don't quite have the same validity as a study where you do basically randomize people to treatments and flip a coin and say, okay, this person gets this treatment versus this person gets another treatment. These are retrospective studies, so I think that has to be taken into account. So one of the studies, one of the latest treatments in melanoma is this LAG3 inhibitor, and so there was a study done of this with this combination. It's the Nivo plus Rela combination. And so in this study, they actually allowed patients with acral and mucosal melanoma to be accrued. And so if you look down here, if you look at the cutaneous melanoma, and I know this is a complicated kind of thing to follow, but if you look at the cutaneous melanoma, you could see that the combination, the Nivo-Rela combination, seemed like it was beneficial as compared, and this is the median line. So anything to this side here shows a benefit of the combination. And if you look at the acral melanoma, that's the second line here, you could see that there was some benefit too, but maybe not as much. And if you look at the mucosal melanoma, you could see that people on generally had a bigger extent of benefit. But then when you look here, so that was the, what we call progression-free survival, meaning how much time you go by without the tumor growing. But then if you look at the survival, the overall survival, you could see that maybe not so much of a benefit, right? You could see that the skin melanoma patients are right here, while the acral and mucosal melanoma patients are here. And so it doesn't seem like from this subset analysis that you're necessarily living more, even though your tumor might be responding better. And I think that's one of the challenges we have with these trials, that because so few patients with these rare subtypes of melanoma are accrued, you don't always have the statistical power to really tell for sure how much of a benefit you're getting. And another study looked at immune checkpoint blockade for these different subsets. And so they had this is from D'Angelo, and a fair number of patients, and they looked at combination therapies. And so this is what they found, that if you looked at mucosal melanoma here, the response rate for just single agent therapy was 23% versus 40% for the cutaneous melanomas. But if you looked at the combination nivolumab plus ipilimumab, it was 37% versus 60% for cutaneous melanomas. And then for Yervoy alone or ipilimumab, it was only 8% versus 21% for cutaneous melanomas. And if you look at this graphically, this is what you see. So here's the nivolumab plus ipilimumab combination. Here's the nivolumab by itself, and here's ipilimumab by itself. And you could see that the nivolumab plus ipilimumab, the more bars you have below that median line, the more response you're having. That just shows what the magnitude of tumor shrinkage is. So you could see here, like maybe about half the patients are having some kind of tumor shrinkage. But over here, you're seeing about 2/3 of patients are having some kind of tumor shrinkage. So it just tells you how much tumor shrinkage you're getting with this combination treatment. And then if you look at what's the duration, how long do these shrinkages last? If you look at for patients who are getting just the single agent therapy, you could see that generally speaking, the duration is pretty good. And then for the combination immunotherapy, the ipilimumab plus nivolumab combination, maybe about 50% of patients are getting a durable benefit. But if you look at just Yervoy by itself, it seems like the median duration of response is very low, like maybe 3 months or so. And then most people are not getting a long-term benefit from treatment. So what about giving people treatment pre-surgery, like Dr. Vaidya was talking about? The pendulum in our field is swung from doing surgery followed by immunotherapy to doing immunotherapy first, followed by surgery, for the same reason that she outlined. Basically, trials are showing that you get more bang pre-surgery than you get post-surgery. So this was a study that was done by Dr. Amaria at MD Anderson and her colleagues. And so they treated 36 patients and with mucosal melanoma, and they gave them checkpoint inhibitor therapy. Either they gave them combination PD-1, CTLA-4, that's what most patients got, or some patients got monotherapy too. And so here's the results. Basically, if you had a pathologic complete response or pathologic partial response, that's where the pathologist is looking at the slides and saying, okay, tumor is totally wiped out or tumor is still present. That's what the pathologic response refers to. You can see that you had a pretty good durability up to 5 years. That's 60 months, like in that blue line. But one thing you'll notice is that if you remember the slides that Dr. Vaidya showed, basically those patients with skin melanoma are almost 90+% of them will have a durable response, based on data that we have. But here you're seeing that it's not quite as durable as a skin melanoma. So again, showing that point that immunotherapy does work for mucosal melanoma, it just doesn't work quite as well as it does for skin melanoma. And then just showing the probability of progression-free survival, and showing that if you didn't have a path response, you could see that those patients really didn't do as well. And if you had a path complete response, you did better. So what about targeted therapy? Dr. Chow was asked this question earlier about the BRAF V600E mutation, which is common in skin melanoma. In mucosal melanoma and acral melanoma, one of the common mutations is in a gene called KIT. And I want to say that maybe 10 years ago, there was a lot more interest in this field than there is today, partly because of the data that I'm showing. Well, there were 3 trials done. We were involved in doing this middle trial, or actually this trial, the Carvajal trial. And so this trial looked at a KIT inhibitor and looked to see how does it work in patients with melanoma with a KIT mutation. So what you'll notice is that if you focus on just this last line, the objective response rate, you can see that the response rate was just not as great as we see with the BRAF inhibitors. With the BRAF inhibitors, it's about in the 70 to 80% range. And here you can see that for this trial, it was 16%. And then for this trial here, the Guo et al., which was done in China, that trial was 23% response. So not quite the same magnitude of response, like maybe only a fourth of the patients having, or fourth or less of the patients having a response. And then if you look at this line here, the progression-free survival, that's how long the responses last. It's somewhere between 3 and 3.5 months. So again, not quite the same response that you get with skin melanoma with the BRAF inhibitors, And just showing this graphically that, and in this trial, you could have acral melanoma or a mucosal melanoma, or you could even have what's known as sun-damaged melanoma, that with the KIT mutation. And you could see that, like maybe 3 or 4 patients had great responses, long-lasting responses, like this last patient with the mucosal melanoma was up to 100 weeks almost. But most people, you're talking a few weeks of response. So kind of disappointing. And I think that's led to people going back to other types of treatments. And so what about BRAF MEK inhibition in patients with acral melanoma? there was a study looking at 48 patients, and they compared acral and non-acral melanoma. That's your standard cutaneous melanoma. And so if you look at the response versus the non-response in those types, see that there's no real difference. Like the acral melanomas seem to do as well or even better, assuming that they had the BRAF mutation. Now, if you remember, the BRAF mutation is only present in about 10% of acral melanoma. So it's not like 50% like in your garden variety skin melanoma. And then if you look at the duration of response, it seems like the duration of response was about the same in both the acral and in the non-acral melanoma with the BRAF mutations. So I'm going to skip over this just only because the percentage of response is being low with the KIT inhibitors in acral melanoma. And people have looked at these different types of mutations like exon 11 or exon 13. It seems like you get better response with the KIT inhibitors with this type of mutation. And so I'm going to conclude by saying that these are rare subtypes of melanoma that are present in only a small percentage of patients with melanoma. They tend to be not as immune responsive as your garden variety skin melanoma, but still patients can have some durable responses to either combination immunotherapy or to single agent immunotherapy. And one area we are very interested in is looking at NRAS mutations. We've done some clinical trials with non-selective RAF inhibitors. So these are RAF inhibitors that are not specific for the BRAF V600E mutation, but inhibit all different types of RAF. And so we think that you can get maybe about 30% response rate with these non-selective RAF inhibitors. The KIT mutations, it's about 10 to 20%. And back to our discussion earlier on about research and how much support research needs, I think clinical trials are needed in this group. And we're actively, and many investigators are pursuing these type of trials. So with that, I'm going to end. And thank you.